This is April Van Buchen, and we're covering Chapter 38, 39, and 40 of the Pharmacology book in today's lecture. Antibiotics are used for infections, and bacteria is what causes the infections. Bacteria can be either gram-negative or gram-positive. Bacteria can be in different shapes, like rods, cocci, coccobacillus, bacillus, and some of the weird ones like fusiform, spirochete. They sound like pasta, don't they? These bacteria are spread through all kinds of different infections. So you could have community-associated infections. So those are healthy people who go to work every day, and then all of a sudden they get the flu, or they get something. So they acquire it through the community. Then you have healthcare-associated infections, and those could be in the hospital or in an outpatient clinic, any kind of healthcare facility where you got the infection. And usually the healthcare associated ones are worse than community associated. So healthcare associated infections are more difficult to treat, and they occur within 48 hours of an admission to the hospital. So sometimes they used to be called nosocomial, and some people still call them nosocomial. And the most common healthcare-associated infection is MRSA. Methicillin-resistant Staphylococcus aureus, MRSA, MRSA, most common. So what's the number one method for preventing the spread of infection? And I know you're silently answering hand washing. It is hand washing. That is the number one way. So then there's the use of antiseptics and disinfectants. So disinfectants kill the organism, and they're usually used on non-living objects. Disinfectants are a cidal agent, C-I-D-A-L. Have you ever heard of that? Like Lysol, cidal agent. Antiseptics are generally inhibit the growth of the microorganism, but it doesn't necessarily kill them. And you can apply an antiseptic to a living tissue. So an antiseptic soap, antiseptic spray. So those are those pumps of soap are antiseptics. So disinfectants kill. They also end in cidal, C-I-D-A-L, and antiseptics inhibit the growth. When a living person or creature has an infection inside of the body, antibiotics are used. So in the beginning, when you have an infection, the area needs to be cultured to identify the causative organism and find out which antibiotic works to kill that organism. And most places will have a culture done, and they'll be put on something called a broad-spectrum antibiotic. And so a broad-spectrum antibiotic works on a lot of different things. And then you get your culture back. And your culture is what determines which specific antibiotic works the best for it. So you always get a culture before you put on any antibiotic. And while you're waiting for the culture results, a broad-spectrum antibiotic is started. And then when you get the culture results back, and in the old days, we used to have to know all of this stuff. We'd have to know what antibiotic works for gram-negative cocci or gram-positive, whatever. But now, you guys you're spoon-fed. The pharmacy, the lab will even say, this is gram-negative, whatever, and these are the antibiotics that work best for it. So then you narrow it down to a more specific antibiotic and take them off the broad spectrum and put them on a more specific antibiotic because it will work faster and more effectively. So does that make sense? You do, somebody comes in with an infection or a suspected infection, you get cultures, put them on a broad spectrum because it takes sometimes 2 days for the cultures to come back, and you want to give them something for those 2 days, so you put them on a broad spectrum. And then when the cultures come back, you look to see which antibiotics will work the best to treat whatever the infection is, and you switch them if you need to. Sometimes the broad spectrum is all they need, but you look. And so many times, especially in this day and age with hospitalists who switch patients every shift and go somewhere else to work, the nurses are the ones that get that lab report, and the nurses are the ones that say, hey, doc, we need to switch them. We got the culture results back. They're on broad spectrum, whatever, and the lab result says that this other antibiotic is best for them. So you make a call to the doctor. So nurses need to know this kind of stuff because they're usually the first ones that get those results back. Okay. And so there's so many types of bacterial infections. There's something called a superinfection. I want you guys to know what a superinfection is. There's another infection that you get that's hospital acquired usually, and it's called Clostridium difficile. It is a type of colitis because it happens in the GI tract. If you guys in clinical have taken care of a C. diff patient, that's what it is, C. diff. And it is just a nasty bacteria that's in the GI tract. It usually occurs in patients who are immunocompromised, so they're sick already. And then all of a sudden they start having episodes of diarrhea. And it's so common in healthcare now that if somebody comes into the hospital, to the emergency room, and they have diarrhea, they're tested for C. diff. And they're treated like they have C. diff until they have 3 stool specimens tested and determined negative. Because we are not risking anything. People die from C. diff. It's horrible gelatinous diarrhea that has a terrible odor. You guys will recognize it one day and know that's, you can just tell that's C. diff. So this slide shows you all the different shapes. See how some of them look like pasta? So you have to kind of have fun with bacteria. Okay, I'm not going to test you on this slide. I just want you to understand. Sometimes you have to be on a couple of different a couple of different antibiotics to really attack and kill the bacteria that you have. And so some of them do a lot of different things. So see where it says cell wall synthesis up here, and under it is a list of crazy terms? These are the name of antibiotics. This is why there's so many antibiotics. So this is cell wall synthesis. These are ones that kill here, right? These are DNA replication, so these will kill the replication so it doesn't grow. So different antibiotics do different things, and the outcome is all the same. Bacterial demise. Kill the bacteria. But they all work in a different way. So this explains, I hope, why someone might be on a few different ones. It attacks from different angles. However antibiotics do their work, there are unique to the medication adverse reactions. And then there's some common adverse reactions. Nausea, vomiting, diarrhea, common adverse reaction. Allergic reactions. Penicillins and sulfonamides are 2 broad classes of antibiotics that many people are allergic to. And the most common severe reaction of any antibiotic, it's the most common severe allergic reaction is difficulty breathing, rash, hives, severe GI intolerance, and a lot of pregnancy-related reactions. And so I have to tell you, my husband said, oh, you're teaching them about antibiotics? Here's one thing I want you to teach all the nursing students. They need to understand the difference between a sensitivity and an allergy. So I'll explain it to you this way. My kids were given amoxicillin when they were kids, and they were given it before Easter, and so I put these little dresses on these little 3-year-olds, and they had this horrible rash. Horrible rash. I mean, it was welts all over their body. That's what amoxicillin does to them. They have a sensitivity, they have a rash. Is that an allergy? No, it's a sensitivity. But so many people in this country say, if they have a rash or if they have a little bit of itching, they all of a sudden say, I'm allergic. I'm allergic. Nope, I'm allergic. And it's not really an allergy. You have to go through allergy testing to really determine if you're allergic. You have to have experienced anaphylaxis if you're really allergic. So just because you have a rash, a little bit of itching, just because it makes you nauseous, people all of a sudden say, nope, I'm allergic, it made me nauseous. So what you need to do is find out what happened to them. So if somebody says amoxicillin makes me have a little rash, but yeah, I got better, but I had a rash for 3 days, if amoxicillin is the best antibiotic to give, still give the amoxicillin. So always ask why and write why down. Otherwise, they're given a stronger medication or a medication that maybe wouldn't work as well. Does that make sense? So always know why if somebody says I'm allergic to an antibiotic. Okay, so there's all kinds of antibiotic therapy. So your antibiotic could be in the urine, in the blood, in the wound, on the skin. You need cultures to determine what the bug is. Empiric therapy is broad spectrum therapy. Empiric therapy is treatment before obtaining the culture information. So you've collected the specimen and sent it off. You just don't know what the results are. Definitive therapy is when you get those results back and you choose an antibiotic that is specific for the bug. And then there's prophylactic therapy, which is, say somebody's having a total joint replacement. They're always given a gram of Ancef or a gram of vancomycin before the surgery to prevent an infection. So prophylactic therapy. So 3 different kinds of therapy. Then you have therapeutic response, which means the symptoms are going away. So what you would expect if somebody's on antibiotics is their fever goes away, their white blood count goes down, their redness or inflammation or drainage or pain goes away. So if they're on antibiotics and they still have a fever, or their inflammation is getting worse, or their pain is getting worse, you know that antibiotic is not working. And you need to notify their provider, switch them to something else, do a different culture, do something, because it's not working. Then there's subtherapeutic response. And that's where the same thing, where it's not working. So therapeutic response is a decrease of all the signs and symptoms. Subtherapeutic response is where the signs and symptoms do not get better. Okay, this slide lists all the classes of antibiotics. They're either bactericidal, which kill the bacteria, or bacteriostatic, which slow down the growth of the bacteria. Doesn't kill them immediately, but it eventually leads to bacterial death, but it slows down the growth. So cidal kills, like Lysol, cidal, and bacteriostatic inhibits the growth. And we'll talk about all these different categories. Sulfonamides are the sulfa drugs. So when people say I'm allergic to sulfa, that's what they're talking about. Okay, so here's sulfonamides. It's one of the first groups of antibiotics. It's often combined with other antibiotics. It's, so let's see if I have, sometimes it's combined, like Septra, Bactrim is a combination drug. So I've got some examples up there. The mechanism of action is they're bacteriostatic. They're effective against gram-positive and gram-negative bacteria. They're great for UTIs. They're great for E. coli. They're great for Staph aureus infections. They're great for upper respiratory infections. So sulfas are used a lot. And I listed the adverse effects here. There's a ton of them. Can you see that? Nausea, vomiting, diarrhea. Look at that. Hepatotoxicity. So do we want to give a sulfonamide to somebody who has liver failure? We would choose something else most likely. Okay. So for nursing implications, you want somebody to take a sulfa with a lot of fluid, 2 to 3 liters of fluid a day. You want to take it with food because it gives you a stomach ache. Then there's beta-lactams. These are the penicillins. And there's cephalosporins, so there's all kinds of stuff, but the penicillins are the biggies. And a lot of people say I have a penicillin allergy, or if somebody has a sulfa allergy, you're not going to give them a penicillin because they're related. Okay, so here's more specific penicillin information. So penicillins bind to penicillin binding protein. And once they're bound, the cell wall synthesis breaks up. So the bacteria cells die. Penicillins just kill the bacteria, they don't kill other cells. And they are great for gram-positive bacteria, like strep, like staph. They're usually well tolerated. A contraindication is allergy. So if people say they're allergic to penicillins, not all penicillins end in cillin, so you have to be real careful. Augmentin is a penicillin. There's one called Zosyn. So don't just assume because it doesn't say cillin that it's not a penicillin. Still look them up. If you have a patient allergic to penicillins and you're not sure that your medicine is not a penicillin, look it up. Lots of medication errors have occurred because penicillin drugs are called by the trade name, which doesn't end in illin, and they're given to patients with penicillin allergies. Lots of adverse effects. Nausea, vomiting, diarrhea is number one. Allergic reactions happen in 1 to 4% of people taking it. They get a lot of itching, and they get what's called angioedema, is the big thing that happens in allergies. So patients allergic to penicillins have an increased risk to all the other beta-lactam antibiotics. I'm going to go back to that slide so you can see. So if you're allergic to penicillins, you're not going to do cephalosporins, you're not going to do carbapenems or monobactams. You're not going to give them any of that. No beta-lactams at all. So for nursing implications, you want to take them with water. Not because not with juices, because some acidic fluids will detract from the strength. I'm saying this really bad. It'll take away from the drug's antibacterial action. It'll make it not work. So not juice. And then you monitor them for an allergic reaction, especially if they're in the hospital and they've never taken a penicillin before, since 4% of the people are allergic to it. Okay, so cephalosporin. I put in bold Ancef because that's super common. Keflex is also super common. I don't know why I didn't bold that. So these are semi-synthetic antibiotics. They're structured very similar to penicillins. They're bactericidal. That's their mechanism of action. They're cidal. They're considered broad spectrum. Cephalosporins are considered broad spectrum because they cover both gram-positive and gram-negative. Now I'm going to flip sides a little bit for you. So this slide has first generation and some examples and things that it's used for. Second generation and some examples, and I didn't give some things that it's used for. And then third, fourth, and fifth generation. And I've given a couple of uses in third, fourth, and fifth generation. So I just said they're considered broad spectrum because they cover both gram-positive and gram-negative bacteria, but some cover better than others. For example, the first generation, Ancef is used a lot. It's used a lot prophylactically for surgical cases. It's used a lot for staph infections. Staph is a bacteria found on your skin, but if you have a cut or something, it can go in and cause a really bad infection. So if somebody has a wound, the most common infection is usually staph. The most common UTI is usually staph, so it's this bacteria that I don't want to say it's not from staying clean, but it should be on the skin, if anywhere, not underneath the skin or in the urinary tract. So the first generation covers gram-positive very well, and gram-negative not so well, but it still covers a little gram-negative. So if I had somebody with an infection and I sent the cultures off and I don't have the culture results back, I might start them on a ANSEF, and hope that it's a gram-positive bug that ANSEF treats. And if not, then I have to switch it to something else, because if it's gram-negative, ANSEF's gram-negative coverage isn't that good. The different generations cover gram-positive and gram-negative a different way. For example, third generation. The third generation cephalosporins cover gram-negative better than gram-positive. They still cover both, so they're still considered broad spectrum, but they cover gram-negative better. An example would be Rocephin. Let's see, ceftriaxone. You guys will give this in your career. You'll give all of these in your career. Rocephin's great for central nervous system infections. It just passes through to the cerebrospinal fluid very easily. It's eliminated in the liver. If someone has hepatitis or any other liver disease, you would not give a third generation cephalosporin. So just because it's a cephalosporin doesn't mean they're all the same. I think that's the message here that I want to deliver to you. So there's 5 different generations. They're used for different things because they're a little bit different. Okay, so here's another class, beta-lactams. So there's carbapenems and there's monobactams. Carbapenems have the broadest antibacterial action of any antibiotic to date. They are used for complicated body cavity and connective tissue infections in really sick people. You have to infuse them over an hour. Sometimes they can cause seizures, and you only give this if they really need them. Monobactams, same thing. They work against aerobic gram-negative bacteria. So the same kind of bacteria, E. coli, Klebsiella, Pseudomonas. They're bactericidal, IV only, severe UTIs or systemic infections. Macrolides. Macrolides are also a synthetic beta-lactam antibiotic. And I'm not going to ask you this kind of stuff on the test. I'm going to ask you like nursing interventions, or I may say what might be best for whatever. We'll do a brief review of it before the test. Remember, nursing questions. What would the nurse do? What should the nurse know? How would the nurse administer? So macrolides are bacteriostatic. They're not bactericidal. Lots of examples. They're used for lots of different things. Some STDs they're used for, Lyme disease, syphilis, different, all kinds of different infections. Lots of GI side effects, so nausea, vomiting, diarrhea. Erythromycin should not be given to people with liver disease because it is hepatotoxic. It can cause you to be jaundice, anorexia. And azithromycin or clarithromycin have fewer adverse effects. They're really a better choice than erythromycin. And tetracyclines. Tetracyclines are broad spectrum, so they're really great antibiotics, but you've got a lot of nursing interventions with them. Okay, they're teratogenic, so we don't give them to pregnant people. We do not give them to children under 8 because they will bind to the calcium in the teeth, and they will discolor the teeth. If it happens, but you don't want it to happen, so we just avoid giving it to the kids. There's also photosensitivity, so you have to warn people about the sunlight. So we're going to take a break from antibiotics. I'm going to tell you about superinfections or superbugs or multi-drug resistant organisms. These are the most common on this screen. There is a threat that MRSA or MRSA is becoming resistant to all antibiotics. So I know you're going to see on the slides that the uses of some of the antibiotics are for MRSA, maybe not much longer. So superinfection is an overgrowth of normal body flora or of an opportunistic organism. So it's where, like, the bacteria is no longer held in check by normal beneficiary flora. Maybe somebody's been on a broad-spectrum antibiotic for a really long period of time, and these antibiotics kill normal flora, and that's where the drug-resistant organisms come into play. So I really want you to understand this. The number one way that you as a healthcare provider can decrease the spread of drug-resistant organisms is not to limit the antibiotics that are being given. That's, doctors need to do that. I mean, everybody needs to just give an antibiotic when it's needed. But what you guys can do as nurses is use your isolation precautions and take isolation precautions seriously. So now we'll go back to antibiotics. Aminoglycosides. Another antibiotic, you need to know the adverse effects. So kidneys and hearing. Kidneys and hearing. This paesthesia should be paresthesia, not paesthesia. Aminoglycosides are great for gram-negative bacteria. Most of them are IV. They are not PO. They're not absorbed well PO. Neomycin is the one exception. So that one is PO. The super serious adverse effects would be renal damage and hearing, so ototoxicity or vestibular toxicity. With aminoglycosides, you need to check drug levels to prevent the toxicity. So you would do peak and trough levels, right? Peak is right after a dose so that you know the most that can be in the system, and trough is the lowest amount that can be in the system to be effective. Quinolones is another class. Quinolones is broad spectrum, gram-negative, some gram-positive. The adverse effects are pretty much the same as all of the other antibiotics, only quinolones can cause tendinitis, which is unique to this class of drugs, and they have a lot of interactions. So with antacids, with other quinolones, with calcium, magnesium, iron, zinc, or Carafate, which is one of your last sets of drug cards you'll use. It's for gastric ulcers. You should take these meds within an hour, like leave an hour in between the quinolone and these meds, either before or after. So here's another slide with all of the interactions. Lots of different interactions for these, and the biggest side effect is the tendinitis stuff. Bunch of different miscellaneous antibiotics, and they're all very commonly used. Cleocin is probably one of the most, I should say, popular one. It's used for bone infections. It's used for urinary tract infections. It's used for GI infections and all kinds of other serious infections. But it might cause C. diff, so you don't use it willy-nilly. You use it if you really need it, but because if it causes C. diff, that's a bad thing. Flagyl is used for a lot of different things, so you're going to see it used for protozoal infections as well, and it's an antibiotic. It is, if you have somebody on Flagyl, you don't want them to drink alcohol. There will be a reaction. There's a reaction with other drugs. It's used for a lot of GYN infections, for abdominal infections. Let's see, any other ones? Then I want to talk about vancomycin a little bit. Vancomycin is used for MRSA. It's used for gram-positive infections. I think you heard me earlier in this lecture say that vancomycin used to be the big gun. We would save vancomycin. If nothing else worked, we would give vancomycin. Now it's given a lot. It's given for a lot of different things. Sometimes it's first choice for things. It is the treatment of choice for MRSA. It is the treatment of choice for a lot of gram-positive infections. For C. diff, oral vancomycin is the antibiotic given. For staphylococcal enterocolitis, it is the treatment of choice. You have to monitor vanc levels to prevent toxicity. It can cause ototoxicity and nephrotoxicity. And it can cause something called red man syndrome. So if you have too much vanc and you're toxic, you can kill your kidneys, you can kill your hearing, and red man syndrome is exactly what it says. Flushing and itching of the head and neck, and your whole body, your trunk, everything makes you turn red. And to decrease the red man syndrome, you give them an antihistamine, and when you stop using the Vanco, it'll go away. But still, it's kind of scary for people. You should infuse Vanc over an hour. So that's miscellaneous. Nursing implications for antibiotics. I've mentioned them with some of the specific antibiotics. You know, some of the ones that you need to drink water instead of milk. So know everything that I've mentioned and everything that's on the slide. Know when not to give the medication. For example, if somebody's taking erythromycin because it's hepatotoxic, you wouldn't want to give it for somebody with a hepatitis or with some type of liver disease, right? Chapter 40, antiviral drugs. So a virus cannot live on its own. A virus can't be sitting out and replicate and grow and get worse. It has to have a host cell, and it lives inside the cell to grow. It uses that cell's energy to grow and replicate. So any drug that kills the virus also kills the host cell. If you remember from antibiotics, some of the slides or descriptions will say it just kills the organism and not the host cell. Viruses kill the host cell, so just know that. Viruses are called opportunistic infections. They occur mostly in immunocompromised patients. And some term differences, so you'll hear antiviral drugs. Those are drugs that treat infections caused by viruses that are not HIV. And then there are antiretroviral drugs, and those are the drugs used to treat infections caused by HIV. This slide shows you a lot of the different viruses, viral illnesses that are out there, and several of them have vaccinations that help prevent them. So CMV, cytomegalovirus, hepatitis, smallpox, herpes simplex, and varicella zoster viral infections are many. I mean, look at this. So there's oral herpes, there's genital herpes, there's chickenpox, Epstein-Barr, shingles. I just realized I have some of these listed twice. Sorry about that. But there's still a lot of different herpes viruses. Women with genital herpes usually have C-sections because it prevents the neonatal herpes, which can cause blindness in babies. Now we're on hepatitis B and C. I want you guys to know the difference. Hepatitis B is milder. There's a vaccination for hepatitis B. Children get hepatitis B. Hepatitis C is the leading cause of liver failure. You get hepatitis B from infected blood, from sexual contact. You can get hepatitis C from alcoholism. The hepatitis C virus stays alive in the air, so if you have a drop of blood somewhere on the table, on the floor, anywhere, it still has living hepatitis C virus in it. In contrast, I know we haven't talked about HIV yet, but HIV dies as soon as it hits the air. So the drugs that are used, the antiviral drugs that are non-HIV antiviral drugs are listed here. So the mechanism of action is they block the enzyme that helps to stimulate the viral reproduction. They're used for all kinds of non-HIV viral infections, so antiviral, non-HIV. And the adverse effects vary with each drug, but you have to always remember that healthy cells are killed as well. Amantadine, it is only good against influenza A, and there's some new guidelines that say it's not even any good anymore for that. It's got some CNS side effects, so insomnia, nervousness, lightheadedness, and some GI side effects. Guess what those are? Nausea, vomiting, diarrhea, anorexia. Rimantadine causes GI upset. Acyclovir is used, a lot of the herpes viruses, it's the drug of choice for these infections. You can use it orally, topically, IV. Okay, here's some more. You'll notice that the drugs down at the bottom, Maraviroc, and I can't even say the generic name, Retrovir is what I know. These are used for HIV infection. You have to be really careful with them because they cause bone marrow suppression. And what does bone marrow suppression do? And you're not producing the cells that you really need to fight infection, right? So you don't want to suppress them too much because they'll be severely immunocompromised. So you have to be careful how much you give and how long you give it for the HIV infections. This slide just shows the life cycle of HIV. If you have untreated HIV, you live about 13 years, and your last few years aren't very pleasant, sadly. There's lots of opportunistic infections, all kinds of different kinds, and when you're immunocompromised, you're at risk for a lot of them. An opportunistic infection is anything. It's a bacteria, a fungus, a virus, a protozoal. There's cancers that are opportunistic. But when you have HIV, the opportunistic infection that you try to not ever get, or you try to control if you get it, is HIV wasting syndrome. So you just waste away. Weight loss, diarrhea, fever. It's just bad. I mentioned the Retrovir as an HIV drug in one of the earlier slides when it listed all the different drugs that are used as antivirals. I don't want you to know the specific names of all the antiretroviral drugs for HIV. What I want you to know is people get 2 or 3 of these drugs together. They're used in combination, and the recipe is different for each person, because you're trying to control the reproduction of the virus. You're trying to limit the side effects or find the recipe that has the most tolerable side effects that somebody can handle. And that's it. So the recipe has to be modified a lot because of the adverse effects. Or maybe somebody's on the Retrovir, right? And their bone marrow is suppressed, and you have to take them off of it and put them on something else, and then wait and put them back on it. And so they're constantly altering drugs to try to get the best effect. Nursing implications for everything that we've talked about, antibiotics, antiviral. You want to take everything as prescribed. You want to teach the patient to take as prescribed. You want to tell them to take their medicine until it's finished, especially antibiotics. We do not want to introduce any more new superbugs. I encourage you to do the sample questions. I encourage you to do the questions at the end of each chapter. I encourage you to do the anti-infective worksheet, and I will post the answers to the anti-infective worksheet, and we'll do a brief review before the test next week. And if you have any questions about any of this material, please come see me, send me an email. Thanks.